Okay. Acute chest pain during pregnancy. Acute chest pain during pregnancy may be a variety of serious conditions. Abrupt onset, severe chest pain associated with abrupt onset, severe chest pain associated with widened mediastinum in a patient who is at late pregnancy or early postpartum should raise concern for aortic dissection. The risk of aortic dissection is elevated in pregnancy due to hormonal changes that alter aortic wall structure and due to hemodynamic stress of pregnancy and delivery. Some patients may have an unrecognized underlying aortopathy, Marfan syndrome, bicuspid aortic valve that predisposes to dissection. These patients' ST segment elevation in the inferior ECG. These patients' ST segment elevation in the inferior ECG lead suggests that the aortic dissection has extended. The aortic dissection the aortic dissection has extended proximally to occlude the ostia of the right coronary artery and can cause myocardial infarction, which is a rare complication of type 1 ascending aortic dissection. Inferior MI due to RCA occlusion may be primarily involve the ventricle, causing jugular venous distension and hypotension with clear lungs. Okay, it's not option B. MI resulting from atherosclerotic plaque rupture is uncommon during pregnancy but can occur in patients with premature atherosclerosis. Acute MI alone would not explain the patient's widened mediastinum and sharp chest pain. Pressure-like chest pain is more common is typical. Okay. 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 Mm, the infant most likely has a heart failure. The infant most likely has a heart failure due to a large VSD. The characteristics hollow systolic murmur, based heart at the left mid-sternal border, at left mid-sternal border, created by left to right shunt, through the defect with VSD size, potentially impacting murmur quality due to hemodynamic difference. A small sized, a small or moderate sized VSD produces a loud harsh murmur. In contrast, a large VSD produces a softer, sometimes inaudible murmur due to less turbulent flow through the large defect. So small or moderate size produce a loud harsh murmur, but the large VSD produces a softer murmur because of its larger defect and less turbulent flow. Okay. Left to right shunting from a VSD. Left to right shunting from a VSD can lead to pulmonary overcirculation and left-sided volume overload. The pulmonary hypertension can cause loud closure of the pulmonary valve, leading to prominent S2, and diastolic flow murmur may be created by large blood volume across the mitral valve. Diastolic rumble similar to mitral stenosis. The left-sided uh, volume overload eventually leads to heart failure, manifesting in infants as a failure to thrive, like poor feeding, poor growth. If a VSD is left if a VSD is left unrepaired for a long period, more than 10 years, the pulmonary overcirculation can eventually cause irreversible pulmonary vascular remodeling and facilitate reversal of shunting to right to left, that is Eisenmenger syndrome. This infant is without clubbing or cyanosis, suggests right to left shunt, and has no evidence of Eisenmenger syndrome. Okay. Yeah. Okay. So if left atrial size is enlarged, though it is mild left atrial enlargement, it indicates Hypertrophic cardiomyopathy. If left atrial size is normal, then it is athlete's heart. And left ventricular wall thickness is more than 15 in HOCM, but less than 15 in athlete's heart. And the cavity size usually decreased in HOCM, but slightly enlarged in athlete's heart. Okay, the main is left ventricular atrial size, cavity size, and left ventricular wall thickness. Okay, you want me to read the explanation? Yes. Okay, Brugada syndrome follows autosomal dominant inheritance, and usually involves mutation affecting cardiac sodium channels. Affected patients have ECG abnormalities. Affected patients have ECG abnormalities and ST elevation in leads V1 and V2 are at increased risk of sudden cardiac death due to left ventricular arrhythmia, but no structural cardiac abnormality typically present. Yes. Okay. So it is acute aortic dissection. This patient's clinical presentation and CT scan finding. Look at the CT scan. Uh, Ascending aorta and descending aorta. There is intimal flap in between ascending and the descending aorta. Looks like uh, aortic dissection. Intimal flaps separating a true and false aortic lumen and are consistent with aortic dissection. Aortic dissection involves ascending aorta. Aortic dissections involving the ascending aorta type A is a surgical emergency with mortality rate 1 to 2% per hour following symptoms, and therefore rapid diagnosis and treatment are critical. The initial management of acute aortic dissection. The initial management of acute aortic dissection uh, consists of anti-impulse therapy, which is aimed to reducing the aortic wall stress via reduced peak blood pressure, reduces peak blood pressure, reduce systolic blood pressure, reduces reduced rise of blood pressure with each systolic impulse, reduced frequency of systolic impulse, reduced heart rate. IV beta blocker, labetalol, are preferred therapy to meet these goals. Beta is one receptor blocker decreases the peak blood pressure and rate of the blood pressure rising during systole, decrease ventricular contraction, strength, and velocity as well as the heart rate. Frequency of systolic impulse. Labetalol has added the effect of alpha-1 receptor blockade, which causes peripheral vasodilation and blood pressure reduction. Adequate pain control also reduces sympathetic drive, reduces blood pressure, heart rate, and contractility, and contribute to a reduced aortic wall shear stress. Got it? Okay. It's the high output cardiac like hyperthyroidism and AV fistula can cause high output cardiac failure. Okay. Okay. So this patient with this patient with AV fistula has multiple findings. This patient with AV fistula has multiple findings suggestive of high output heart failure. High output heart failure involves increased cardiac output. It involves increased cardiac output in response to a disturbance that cause reduced systemic vascular resistance that causes reduced systemic vascular resistance. Such disturbance include bypass of systemic arteriolar resistance, bypass of systemic arteriolar resistance due to and AV fistula as in this patient, peripheral vasodilatation due to unmet metabolic demand and hyperthyroidism and severe anemia, peripheral vasodilatation due to hormonal mechanisms or other factors, morbid obesity, cirrhosis. In response to low SVR, the left ventricle increases contractility. The left ventricle increases contractility and stroke volume to maintain adequate cardiac output for tissue perfusion. These increases in stroke volume leads to high amplitude pulsation and hyperdynamic circulation evidenced by widened pulse pressure more than 60 millimeter uh, difference between systolic and the diastolic pressure, brisk carotid upstroke and warm extremity. Heart rate is also increased to aid cardiac output. The reduced SVR The reduced SVR and increased cardiac output also lead to increased cardiac preload. Despite despite high output, the left ventricle is unable to keep up with the increased venous return, and venous hydrostatic pressure increases, causing peripheral swelling and pulmonary edema. Eccentric eccentric lower mm, eccentric left ventricular hypertrophy may develop. Eccentric left ventricular hypertrophy may develop laterally displaced may develop lateral that is laterally displaced point of the maximal impulse, and the high output high blood flow can create a systolic flow murmur. Okay, look at the box. High output failure. Pathophysiology is decreased SVR, systemic vascular resistance due to leads to increased cardiac output and increased venous return. And causes are morbid obesity. Most common morbid obesity, AV fistula, congenital or acquired hyperthyroidism, severe anemia, advanced cirrhosis, Paget's disease, thiamine deficiency. Clinical presentation, hyperdynamic circulation, peripheral and pulmonary edema, laterally displaced point of maximal impulse, systolic flow murmur, echocardiographic finding dilated left ventricle, right ventricle, and inferior vena cava, dilated left ventricle, right ventricle, and inferior vena cava, and elevated resting cardiac index. Got it? Okay, substernal chest pain can occur in both angina and GERD. Substernal chest pain can occur in both angina and GERD. However, the likelihood of GERD versus angina can be distinguished based on thorough history. Although this patient has a history of coronary artery disease, although this patient has a history of coronary artery disease, his current symptom based on more suggestive of GERD, more suggestive of GERD. Okay, prolonged symptom duration, pain lasting for an hours, positional in nature, pain worse with recumbency, and accompanying symptoms of cough caused by aspiration, cough reflux, and non-response to GTN. Non-response to GTN. GERD is diagnosed clinically. GERD is diagnosed clinically. Management includes lifestyle changes, weight loss. Management include lifestyle changes, weight loss, and head of bed elevation, and acid reflux. Medication proton pump inhibitor is recommended for patients with frequent 2 or more than 2 days a week or severe symptoms, and should be started next in this patient. In contrast, angina is intermittent pain. Angina is intermittent pain, short duration, 2 to 5 minutes, and that is frequently aggravated by activity and relieved by rest or glycerin. Coronary catheterization is reserved for acute coronary syndrome, persistent angina despite medication therapy, maximal medication therapy, or extensive ischemia seen on non-invasive testing. Okay. Okay, the risk of sudden cardiac death is increased in individuals with prior MI complicated by left ventricular systolic dysfunction with ejection fraction less than 30%. The majority of the sudden cardiac death in this population results from ventricular arrhythmia, usually in the form of ventricular tachycardia, degenerating ventricular fibrillation. Following MI, patients should be placed on appropriate medical therapy with a beta blocker, metoprolol, AC inhibitor, ARB, possibly mineralocorticoid antagonist, spinal actin. In many patients, any systolic dysfunction following MI will normalize or significantly improve with medical therapy, lowering the risk of SCD. However, in patients with persistent left ventricular ejection fraction less than 30%, despite more than 3 months of optimal medical therapy, the risk of sudden cardiac death remains high, and primary prevention with placement and implantable cardioverter defibrillator is indicated. ICD placement is recommended. ICD placement is also recommended in patients with symptomatic heart failure and left ventricular ejection fraction less than 35%, regardless of MI history. Got it? Yes, looks like ventricular tachycardia. Okay, non-sustained ventricular tachycardia is defined as three or more than three consecutive ventricular beat at a rate of 100 per minute with a duration less than 30 seconds. It is usually asymptomatic and incidentally noted on continuous uh, ECG monitoring appearing as a burst of regular wide complex tachycardia. Although non-sustained ventricular tachycardia can occur in the setting of structurally normal. In the setting of structurally normal heart, and more commonly there is an underlying predisposing condition such as cardiomyopathy or ischemic heart disease with prior myocardial infarction. Frequently, such patient and underlying risk develop non-sustained ventricular tachycardia in the setting of reliable in the setting of reversible precipitating factor that increases cardiac automaticity and encourages the development of both non-sustained ventricular tachycardia and more serious ventricular arrhythmia. Sustained VT ventricular fibrillation. Therefore, rapidly identifying and treating reversible precipitant of non-sustained VT is critical to curtail the risk that a more serious arrhythmia will develop. The patient established cardiomyopathy was established with a heart failure and likely developed uh, electrical abnormality, hypokalemia, hypomagnesemia as a result of loop diuretic administration. Monitoring and adequately replacing electrolytes will likely stabilize the cardiac membrane and reduce susceptibility to non-sustained VT and other ventricular arrhythmia. Adding or increasing the dose of beta blocker metoprolol can also help treat non-sustained VT by inhibiting cardiac sympathetic tone and reducing ventricular automaticity. In patients with no known predisposing condition for ventricular arrhythmia, non-sustained VT should prompt an investigation echocardiography for underlying predisposing disease. Got it? And the option A is antiarrhythmic drug amiodarone is for sustained monomorphic VT. Look at the sustained monomorphic VT. Both has wide QRS complex like monomorphic VT. Like all the VTs has a wide QRS complex, but it is actually sustaining the QRS complexes. But that one actually got normal. Non-sustained is getting normal after uh, 3 or more consecutive ventricular rate beat. Got it? Is it coarctation? Hypertension in the upper extremity and hypotension in the lower extremity. Yes, immediate therapy is aimed at increasing at but yes, we are trying to. Yes, PDA after, isn't it? That's why there is hypertension in the upper extremity and hypo in the lower, like upper extremity blood pressure is slightly higher than the lower. Systemic blood. So according to the picture, how you remember the option, like systemic blood flow via right to left duct ductal shunting. Okay. Yes. Yes. And we are maintaining the systemic blood flow. Blood. Yes. So pulmonary to aorta. Okay. So this neonate has pulmonary. This neonate has pulmonary edema and cardiomegaly. This neonate has pulmonary edema and cardiomegaly, in addition to decreased urine output and lactic acidosis, which are findings concerning for acute heart failure complicated by cardiogenic shock hypoperfusion, given the patient's lower extremity, hypotension and poor femoral pulses, lower extremity hypotension and poor femoral pulses relative to the upper extremity blood pressure and the brachial pulses. The most likely cause is severe aortic coarctation manifesting after closure of the ductus arteries. In utero, deoxygenated blood flows from right side of the heart to the placenta for oxygenation via ductus arteriosus and the descending aorta. After birth, the ductus arteriosus begins to close and blood flows to the lungs for oxygenation due to due to pulmonary decreased pulmonary vascular resistance and increased pulmonary vascular resistance and increased systemic vascular resistance. In coarctation, the ductus arteriosus initially provides a route for blood supply to the descending aorta. Upon the ductus arteriosus closer, uh, blood delivered to distal tissues through a severely narrowed aorta alone is inadequate, causing poor distal perfusion. In addition, increased left ventricular afterload due to aortic coarctation can lead to congestive heart failure, edema from pressure overload. Patient with suspected aortic coarctation should receive prostaglandin E1 to maintain the patency of the ductus arteriosus. This allows blood from pulmonary artery to supply the descending aorta, right to left shunting, restoring distal perfusion. Okay. Yes. Okay, it's the ASCVD scoring age more than 40 with diabetes. So this patient will get lifestyle modification along with statin. Yes. Prince Edward, prominent oxyfoot, rocker bottom feet, intellectual disability, non-disjunction, clenched fists, and E means low set ears, and it is associated with BSD. Uh, Non-disjunction, mitotic non-disjunction may not be present in here. I don't know. In Down syndrome, there is non-disjunction. I have said on that aspect. Yes, trisomy. Yes. Okay. Common surgical indication for infective endocarditis. Common surgical. In MR, always surgical consultation. As far we have read a box where asymptomatic or less than 60% ejection fraction or symptomatic less than 30%. Everybody needs the valve replacement. You remember the box? It's not AS. AS has certain criteria. AS has 3 and 3 criteria like a severe AS criteria and severe AS plus one of the criteria need valve replacement. But MR has a criteria where, in short, on that criteria, what I understand that we need valve replacement. Okay, I'm reading. Okay. Common surgical indication in infectious endocarditis, acute heart failure, extend acute heart failure, AR, aortic or mitral valve regurgitation, extension of infection, abscess, fistula, heart block, difficult to eradicate organism like fungus, MDR pathogen, persistent bacteremia on antibiotics, and large vegetation or persistent septic emboli. This patient this patient who uses IV heroin has subacute non-specific symptoms, fever, leukocytosis, and mitral valve vegetation indicating infective endocarditis. His acute shortness of breath, pulmonary edema, and bilateral lower extremity edema suggests that he is in heart failure, likely due to severe MR from infectious destruction of the valve. Heart failure is most common cause of death in patients with infective endocarditis and most commonly occurs with or the mitral valves, infections of the aortic or mitral valves. Although patients with IV drug use are the most likely to develop right-sided infective endocarditis. Right-sided infective endocarditis, isolated or concurrent infection of the left-sided heart valve frequently occurs. Infective endocarditis can have local or systemic complication. Patients can deteriorate rapidly. Urgent surgical intervention is indicated in those with any of the following: heart failure from valve dysfunction, as in this patient, localized extension of infection, abscess, fistula, heart block, difficult to treat pathogen, fungi, multi-drug resistance organism, and very high risk embolism, large valvular vegetation, or persistent septic embolization despite appropriate antibiotic therapy. Yes. Okay, I never correct this question. Okay, I have always done wrong. I have always done wrong. Okay, this patient's presentation is consistent with digoxin toxicity. Digoxin toxicity most likely due to addition of amiodarone to his medication regimen. Acute digoxin toxicity typically presents with GI manifestation, anorexia, nausea, vomiting, along with possible weakness and confusion. Chronic digoxin toxicity. Chronic digoxin toxicity presents with less profound GI symptoms but more significant neurologic lethargy, fatigue, confusion, disorientation, and visual changes in color vision, scotoma, blindness symptoms. Amiodarone or verapamil, quinidine, and propafenone increases the serum levels of the digoxin by interfering the digoxin metabolism can lead to toxicity in a patient who has previously been on a stable digoxin regimen. It is recommended that the digoxin dose to be decreased 25 to 50% when initiating amiodarone therapy. So digoxin dose should be decreased 25 to 50% when you are using amiodarone with close monitoring of the digoxin level once weekly for the several next week. Yes. Okay, the most important like treatment of symptomatic peripheral arterial disease. Look at the treatment of symptomatic peripheral arterial disease. Smoke cessation, blood pressure and diabetes control, antiplatelet and statin therapy in step A and step 1B. There is exercise therapy, supervised exercise therapy, and in step 2 silostazole preferred over pentoxifylline, and in step 3 revascularization for persistent symptom, symptom, angioplasty with or without stent placement, and autogenous or synthetic bypass graft. Okay, this patient's clinical presentation and ankle brachial index. Normal ankle brachial is 0.9 to 1.3. Ankle brachial index findings are consistent with intermittent claudication of the lower extremity due to peripheral arterial disease. Peripheral arterial disease PAD is a coronary artery disease risk equivalent Therefore, management should include aggressive risk factor modification with counseling for smoke cessation, lipid lowering therapy, lipid lowering therapy, and evaluation and treatment for hypertension and diabetes. The patient, this patient has been appropriately prescribed. This patient has been appropriately prescribed low dose aspirin and high intensity statin, atorvastatin, rosuvastatin to reduce the overall cardiovascular risk. The next step is to enroll the patient in a regular exercise program. Exercise therapy for minimum 12 weeks with 30 to 40-minute walk at least 3 times a week, and is recommended for all patients with intermittent claudication. Exercise therapy for a minimum 12 weeks with a 30 to 40 minutes of exercise at least 3 times a week, recommended for all patients with intermittent claudication. The goal is to reproduce the claudication symptoms during each session, which are likely to improve ischemic conditioning of the skeletal muscle and gradually increasing the exercise capacity. A supervised exercise program is preferred, but unsupervised programs are also beneficial. Supervised exercise program has been shown in multiple clinical trials to reduce symptoms and improve walking distance. Okay, so okay, no, I just want to summarize like step one, two, step 1A, 1B, 2, and 3. Okay, go ahead. Next. No. Just remembering because you know everything like what we are giving in the peripheral arterial disease. We are giving aspirin, we are giving statin, we are giving BP medications, we are giving diabetes medication. We know that, and smoking cessation is a number one thing. But the sequence actually we do not remember. Then we prefer the supervised exercise program in 1B, and I have told you that we use silostazole, and it is preferred over pentoxifylline. If everything falls, then we will go for revascularization. So vascular surgeon is the last, so we can do step 1A, 1B, and step 2. uh, okay. Then yes, in 1A the basic medication like what we do in the for what we do for any sort of atherosclerotic disease. Okay, so laparoscopic intervention is minimally invasive option for a number of intra-abdominal surgeries: cholecystectomy, hysterectomy. Preparation for the surgery requires insufflation of the carbon dioxide gas into the abdominal cavity to create space for surgical maneuvering and to facilitate adequate camera visibility during the procedure. Carbon dioxide is introduced into the abdomen via needle or port or with continuous monitoring of intra-abdominal pressure. Peritoneal stretch receptors sense the increase in intra-abdominal pressure and respond by triggering increased vascular tone. Close monitoring is required as patient may develop severe bradycardia, AV block, sometimes asystole. This increased intra-abdominal pressure can also cause mechanical increase in systemic vascular resistance, leading to elevation in blood pressure. Yes, carbon dioxide gas embolization is a rare complication of carbon dioxide insufflation, usually resulting from inadvertent insertion of the insufflation needle directly to directly into the artery or vein or organ. Affected affected patients typically develop an end organ infarction, arterial embolism, or hypotension and obstructive shock, venous embolism. Severe bradycardia and AV block are not expected. Severe bradycardia and AV block are not expected. Okay, choice B, agents used for general anesthesia. Propofol commonly have cardiac suppressive effect. Therefore, inadequate anesthesia is expected to cause tachycardia. Inadequate anesthesia is expected to cause tachycardia rather than bradycardia. Okay, choice D. Systemic absorption of intra-abdominal carbon dioxide can occur during laparoscopic procedure, leading to an increase in blood of PaCO2. This causes peripheral vasodilatation with reflexive increase in heart rate. Vena cable compression can result from high intra-abdominal pressure. However, monitoring of intra-abdominal pressure makes significant compression unlikely. In addition, cable compression would lead to decreased venous return with reduction in a cardiac output and a reflexive increase in heart rate. Got it? It's cardiac issue, isn't it? Yes. So first one, like autonomic dysfunction, is like just like postural hypotension. So he does not has postural hypotension. Sorry, if pulse is 64, then bradyarrhythmia is not happened. Is there? It may be cardiomyopathy or heart disease. Yes, it's bradyarrhythmia. Okay, I'm reading the explanation. I don't understand the. Okay, from choice F, start with the downwards. Okay, torsades is a polymorphic VT that can be triggered by prolonged QT interval. So torsades point is polymorphic VT. So no relation in here. Okay, premature QT torsades, yes. So as there is normal QTC, so it cannot be torsades. Okay. So premature ventricular beat, usually asymptomatic and can cause palpitation in some patients. Isolated premature ventricular beats in a patient with normal ejection fraction is not associated. Okay, premature ventricular beat is not associated with syncope. Got it? No, sorry, non-ST, non-sustained ventricular tachycardia. You are talking about that. May not be. Okay. Choice D. This patient has no reported symptoms preceding aura, tonic movement, or postictal phase, suggesting a seizure. So he has no such feature. Uh, so generalized seizure is not equal to syncope. Okay. Choice C. Decreased myocardial contractility from conditions like cardiomyopathy or ischemic heart disease predisposes to serious ventricular arrhythmia, ventricular tachycardia, paroxysmal ventricular tachycardia, and can cause syncope. However, the patient's normal left ventricular ejection fraction on echocardiography makes this less likely. And choice A, postural hypertension due to autonomic dysfunction. Postural hypertension due to autonomic dysfunction can cause presyncope or syncope. However, this patient's supine or standing blood pressure are not consistent with orthostatic hypertension. More than 20 millimeter of pressure drop and more than 20 millimeter of drop in systolic blood pressure with position changes. Okay, now the main explanation. Syncope refers to an abrupt and transient loss of consciousness. Transient loss of consciousness with loss of partial tone, followed by spontaneous and complete recovery. It is usually benign and self-limiting. Vasovagal syncope, can it can be the initial but it can be the initial presenting symptoms of a life-threatening disease process, cardiac syncope. The cause of syncope can often be determined by careful history taking, physical examination, simple lab tests, and ECG. This patient has conduction system abnormality, including prolonged PR interval, intraventricular conduction delay, prolonged QRS, complex duration on ECG. This is suggestive of a bradyarrhythmia or high-grade AV block as the most likely cause of his syncopal episode. AV block with associated bradyarrhythmia can often be intermittent and is likely responsible for this patient's prior episodes lightheadedness left over the past month. The fact his heart rate is currently normal does not exclude bradyarrhythmia due to intermittent nature of the block in many patients. That's the answer of your question. So we do not know that he has the fact that his heart is currently normal does not exclude bradyarrhythmia due to intermittent nature of the block in many patients. He should be referred for additional electrophysiologic testing and evaluation for pacemaker implantation. Yes. What's his creatinine? He is on dialysis catheter. You can say uremic pericarditis. You are talking about this. Wait. Okay. Why you choose ibuprofen? Okay, look, what you have told. Is it uremic pericarditis? The patient, if the patient is on dialysis and you are giving, just think simply, your patient is on dialysis and you are giving like NSAIDs, is it logical? So that's why I ruled it out. Yes, it is like pericardial effusion, pericarditis, all are closer, and ibuprofen and colchicine is one of the drug where there is viral pericarditis. Yes, and we are trying to uh, relax him by clearing all the fluid from his body, like fluid from the heart, fluid from the lung. Why we are doing dialysis, isn't it? Okay. So this patient has fever, chills, leukocytosis with left shift, new arrhythmia, and a pericardial effusion on echocardiography. This presentation is more or most concerning for purulent pericarditis. This presentation is most concerning for purulent pericarditis. Purulent pericarditis is a purulent pericarditis is an acute febrile purulent pericarditis is an acute febrile illness resulting from bacterial infection of the pericardium, and the most common cause is staph aureus. Chronic hemodialysis is associated with fluid shift and bacteremia, places patients at increased risk. Other causes include direct spread from intrathoracic infection, pneumonia, inoculation of the bacteria into the pericardium during cardiothoracic surgery. Purulent pericarditis is rapidly progressive and highly fatal, hence prompt diagnosis and treatment is necessary. Okay, next. Okay, okay. Affected patients, fever, chills, fatigue, chest pain, appear severely ill on examination. Tachycardia is typical, and sometimes new arrhythmia can occur due to epicardial inflammation and irritation. Pericardial effusion are commonly develops. Pericardial effusions are commonly develops due to an extensive, sorry, due to executive fluid buildup, due to executive fluid buildup in the pericardial space, and can lead to distant heart sound, low voltage QRS complex on ECG, uh, low voltage QRS complex on the ECG. Chest X-ray may show an enlarged cardiac shadow with a clear lung. Cardiac tamponade on physical examination may develop. Echocardiography confirms the pericardial effusion but cannot distinguish whether it is purulent. Therefore, when purulent pericarditis is suspected, urgent pericardiocentesis is indicated for both confirmation of the diagnosis and treatment. Purulent fluid is usually turbid due to a high leukocyte count, and gram stain and culture often reveal the causative organism to guide antibiotic therapy. Got it? Anti-anginal drug. Okay, this patient most likely has vasospastic angina, formerly known as variant or principal angina, hyperactivity of the intimal smooth muscle in the coronary arterial disease. Coronary arterial wall leads to intermittent coronary artery vasospasm. An imbalance in autonomic stimulation likely plays a role. Patients with vasospastic angina typically have recurrent episodes of chest discomfort that resolve spontaneously within 15 minutes. The episodes commonly occur during sleep and may be accompanied by diaphoresis, nausea, palpitation, dyspnea. Patients are typically young and can lack most risk factor for coronary artery disease, hypertension, diabetes. However, smoking is not a strong risk factor. The diagnosis is typically made by ambulatory ECG demonstrating contiguous ST segment elevation during an episode of chest discomfort. Coronary angiography is usually performed to rule out the atherosclerotic coronary arterial disease. Preferred treatment is smoking. Preferred treatment is smoking cessation and initiation of the calcium. Preferred treatment is smoking cessation and initiation of the calcium channel blocker to dilate coronary arteries and help prevent an anti-anginal episodes and help prevent an anti-anginal episodes. Diltiazem is a weak arterial vasodilator but potent coronary arterial dilator is commonly used. The dihydropyridine, amlodipine, felodipine are most effective. Sublingual nitroglycerin is used to limit myocardial ischemia or once an episode occurs. Got it? Our mistakes are similar. Okay, in the Doppler, they have found. So you need to do CT angiography. Okay, these patients acute onset right leg pain. These patients acute onset right leg pain with pallor and absent lower extremity pulses is concerning for acute limb ischemia. Acute limb ischemia can result from rupture of an atherosclerotic plaque in the peripheral arteries or from embolization of the cardiac thrombus. This patient with a previous anterior MI and heart failure with reduced ejection fraction is a risk for embolization of the left ventricular mural thrombus. Patients with acute limb ischemia should immediately receive anticoagulation heparin infusion. Further management is then determined by the severity of the ischemia. Patients such as this one signs and symptoms of acute limb ischemia, but pulses detectable by arterial Doppler or no motor or sensory deficit have viable limb with no active tissue loss. These patients should undergo imaging with CT angiography and characterize the location and the extent of arterial obstruction, followed by urgent based or surgical revascularization. Patient with pulses that cannot be detected by arterial Doppler or partial motor sensory loss have been immediately threatened limb and should undergo emergency surgical revascularization to save it. CT angiography is helpful in such cases but may not always be temporarily feasible. So if we don't palpate the pulse by like digital pulsation, and if we find via Doppler, then we will go for CT angiography. If Doppler cannot detect, or then we will immediately go for emergency surgical revascularization. That's the key. Okay. And the third one, patient with undetectable Doppler pulses and profound motor and sensory loss have an irreversibly ischemic limb, non-viable limb that requires surgical amputation. Non, yes, 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 yes. If Doppler cannot detect and sensory loss uh, have an irreversibly ischemic limb, like that requires surgical amputation. But partial motor or sensory loss means there is something present, so we will immediately go for the emergency surgical revascularization. And if there is sensory is not intact, so that means amputation. Yes, Wait. Uh, then yes, in hemorrhagic shock, like it's a hypovolemic shock, isn't it? So right-sided preload, left-sided preload will be low. Right-sided preload is central venous pressure. Left-sided preload is pulmonary capillary wedge pressure is low, and isn't it hemorrhagic shock? Okay, wait. Okay, wait. I am not. I haven't given my answer. Yes. Okay, I am right. These questions are very hard. Before giving the answer, you have to be oversure. I have I do wrong multiple times this type of question, and I am just frustrated with this box. I I have written in my notebooks plenty of time, but still I make mistake whenever I am finding the answer. Okay, so I'm just reading the box again. Okay, then we will take a break. Okay. Okay, uh, in hypovolemic shock, everything is down, like right-sided preload, left-sided preload, cardiac index is low, but SVR is high, systemic vascular resistance is high, and the SVO2 is actually significant only for the distributic shock. Uh, That's why I actually skip the SVO2. Got it? Like mixed venous oxygen saturation actually everywhere is low, and it is increased in distributive shock, and it is significant for distributive shock only. And in cardiogenic shock, right-sided preload is higher, left-sided preload is higher, cardiac out index or is low, but SVR is high. In obstructive shock, uh, it may be tension pneumothorax, it may be cardiac tamponade. In obstructive shock, right-sided preload is higher, left-sided preload is low, but in tamponade, left-sided preload is decreased, but measured pulmonary capillary wedge pressure is paradoxically elevated due to external compression by the pericardial fluid. So, measured PCWP may be higher in tamponade. The main cause is tension pneumothorax and cardiac tamponade. So, in tension pneumothorax, right-sided preload is higher, left-sided preload is low, cardiac index is low, and SVR is higher. In distributic shock, everything is low, but cardiac index is higher, and mixed venous oxygen consumption is higher. Got it? Okay. Okay. The patient with incomplete abortion, open cervical os, vaginal bleeding, and accompanying evidence of poor organ and tissue perfusion, that is altered mental status, weak peripheral pulse, have likely has hypovolemic shock. Hypovolemic shock due to massive hemorrhage. Hypovolemic shock due to massive hemorrhage. Loss of intravascular volume increases loss of intravascular volume. Mm, so Loss of intravascular volume decreases right ventricular preload, leading to downstream decrease in pulmonary capillary wedge pressure, a representation of left atrial pressure. There is a consequent decrease in the left ventricular preload, resulting in decreased cardiac output and decreased systemic blood pressure. These in turn stimulates the sympathetic nervous system, leading to an increased heart rate and peripheral vasoconstriction, increased systemic vascular resistance in an attempt to maintain blood pressure. Got it? Okay. Okay.